And RTA is part of differential diagnosis of a number of pediatric endocrine conditions. Unfortunately, it's a non-specific presentation. So often there may be confusion in terms of diagnosis. The key question is it really RTA? If it's RTA, what type is it? And finally, what's the underlying cause? So as I said, RTA has a wide mode of presentation. Anybody who is not gaining weight, especially and height, so it's a nutritional pattern growth failure, refractory rickets with a low or normal phosphorus, renal calcification with normal serum calcium, periodic paralysis with hypokalemia, polyuria, which is unexplained etiology, and acidotic breathing, we should always think of RTA. Now, of course, growth failure is because of the direct effect of acidosis, as is rickets. The problem of calcification is because of hypercalciuria, specifically in the setting of a distal RTA. Periodic paralysis is more common, Vibha, in which condition? Distal or proximal? Distal RTA, because there the hypokalemia is more severe. And polyuria is largely because of, why do you have? Hypokalemia. So because of hypokalemia, you have nephrogenic DI that causes polyuria and acidotic breathing as part of the acidosis. So when you say renal tubular acidosis, the term is very evident. As I said, diabetic ketoacidosis, you say hyperglycemia, ketosis and acidosis. So this should be renal tubular, which means non-glomerular, and acidosis. So what you need to have is there is metabolic acidosis with a base excess, of course, is the best marker of metabolic acidosis. Along with that, you need to have a normal anion gap and an ammonium secretion, which is defective with a normal creatinine. That's a basic fundamental principle as far as RTA diagnosis is concerned. One of the cornerstones of diagnosing RTA is the anion gap. So anion gap is the difference between unmeasured negative ion versus unmeasured positive ion. But when you talk about in the measured sense, you can say it's the difference between the measured positive ion, which is sodium, versus the unmeasured ion like chloride and bicarbonate. So it's basically sodium minus chloride minus bicarbonate. The usual level is around 10 to 12. If you have accumulation of organic acids like ketones, like lactic acid, like organic acids, you will clearly have a elevated or an increased anion gap. That is very, very common in those metabolic scenarios. However, if the cause of acidosis is predominantly either a bicarbonate loss or a proton gain, you will have a normal anion gap metabolic acidosis. So there are very few differentials of a normal anion gap metabolic acidosis. One, of course, is renal tubular acidosis. The second is gastroenteritis. Third is ureterosigmoidostomy. And fourth is the use of acetazolamide. So this is like a very, very limited differential. So anion gap is a very, very important investigation to start off whether you're dealing with RTA or not. Now, once you have got an anion gap which is normal in a child who has metabolic acidosis with a normal renal function, I said there are two major causes. One is renal and the other is renal in the sense of renal tubular versus a gastrointestinal loss. So how do you differentiate the two? For that, you have to look at the acidification of the urine. Now, how do you assess acidification? We have discussed that it's the ammonia which actually goes along with protons. So ammonium production is a good marker. So what you're looking at is to detect NH4 plus in the urine. Now, how do you detect NH4 plus? Of course, this cannot be done in an easy way. You have to use indirect way. So one method is urinary anion gap. Again, the same thing, difference between unmeasured negative versus measured negative, or if you say sodium plus potassium minus chloride, that's what really means is the urinary anion gap. Now, if your ammonium is high, what will happen to the urinary anion gap? It will be negative because you're not measuring it, it will become negative, while if it's defective, it will be positive. So very clearly, in conditions like diarrhea, you will have increased ammonium production. The urinary anion gap will become negative, and you can really identify that. While whether you have a distal or a proximal RTA, the ammonium production is impaired. So your sodium and potassium will be more than the chloride. And clearly in this scenario, you will have a positive anion gap. So this anion gap in the urine is a good test to go in terms of identifying. There's another very interesting term of urinary osmolar gap. Now, when you say urinary osmolar gap, you are measuring the difference between the measured urinary osmolality versus the calculated urinary osmolality. So you basically calculate the same way. You multiply by sodium by 2, 1 by 2.5 and glucose by 18. If you just want to use sodium, what formula will you use for urinary osmolality? Urinary sodium to urinary osmolality. 4 times urinary sodium is usually the osmolality. So if you find that the measured osmolality is much more than the calculated osmolality, it means there is some new osmol which has been produced, and most common this is ammonium. So normally, if you have an increased ammonium production, this osmolar gap will go up. However, a caveat is that if you have a urease producing infection, you will of course have more ammonia coming in, which may be falsely giving you a negative scenario in that regards. So in GI losses, what you find is that your osmolar gap in that scenario will be increased because you're producing more ammonium. It will be more than 400, while in RTA, this is impaired and your osmolar gap will be less. So both urinary anion gap and osmolar gap are two tests which help you distinguish between these two conditions. So we have a 2-month-old boy with failure to thrive and diarrhea. pH is 7.16. There is metabolic acidosis. Base excess is -16. So Dhwani, in this scenario, anion gap is 12. How will you differentiate whether this is GI versus a renal tubular loss? So normal anion gap, metabolic acidosis. So you will check for the urinary anion gap. These are the values. What do you think now? So clearly your chloride is much more compared to the sodium and potassium, which means that you have some other positive form which you have not measured, which is ammonium. So this is more likely to be a GI loss. 12-month-old girl with failure to thrive, Alapan, pH is 7.12. There is metabolic acidosis that we are seeing. In this scenario, you are seeing this is the sodium, potassium and chloride. What do you think here? $144. So 144 minus 12 minus 110. So it's definitely on the higher side. So do you think this is RTA? You have to start thinking of something else. I've seen many patients who are labeled as RTA, but the anion gap was not measured and they actually turn out to be organic acidemia. So anion gap clearly in this case is high. We have to think of some form of a organic acidemia in this setting. 5-year-old girl with rickets and polyuria, Vibha, weight is very less, height is compromised, there is metabolic acidosis and urinary pH is high. So somebody said you have acidic urine, acidic blood, and the urine is not acidic. This seems there is an acidification defect. So do you agree this is distal RTA? So there is acidosis and the urinary pH. So you have to do other tests. Anything else before that? So renal tubular acidosis. So you should always look at glomerular causes also. So in this regards, phosphorus was high. So always creatinine should be measured. Of course, some people do measure, but we have seen cases in which blood gas was done and creatinine was not done, which is a bit unusual, which is not something which is pardonable. It should definitely have been done. Now we know that this is RTA. The question is it type 1, type 2, proximal or distal RTA? Type 4 RTA is very simple. You will be having hyperkalemic variant. Acidosis is not severe. They will have mostly polyuria, failure to thrive. You will be able to identify them easily. Main aim is to distinguish between proximal and distal. So urine pH is a good test. Anybody who has acidosis should have an acidic urine. If your urine pH is more than 5.3, this goes more in favor of a distal RTA. Now, infection can cause some confusion, especially if you have a urease producing bacteria. You will have more production of ammonia and you will have an alkaline urine, as we saw in the first case. So whenever you're using urinary pH, you have to look at two things: urine routine microscopy to exclude UTI and a urinary sodium to exclude dehydration. If somebody is dehydrated and if somebody has a urine infection, your levels of urine pH will not be reliable in that regard. So dehydration, again, low urinary sodium, your acidification may be defective because sodium is required from that perspective. So before you really look into urine pH, look into urine RM and urine sodium. Only if they are fine, then you should go ahead with urinary pH. Fractionation of bicarbonate should be measured only when you have a reasonable amount of bicarb. If your bicarb is 13 or 14, your Fe bicarb will be low and you will say this doesn't fit like proximal, this looks like a distal RTA. But you should ideally do it once your bicarb is around 20 or above. And then of course you use the fractional excision of bicarbonate, which is basically urinary bicarb upon serum bicarbonate into plasma creatinine upon serum urinary creatinine into 100. So this is how you will measure in that regards to distinguish proximal and distal. So levels are usually less than 10% in distal and more than 10% in proximal. Other measure which is considered to be a very gold standard measure to differentiate proximal to distal RTA is the urine to blood CO2 difference. Now urine to blood CO2 difference is a marker of distal acidification. If the difference is less, it means there is a problem in acidification. If the difference is good, you are really acidifying well in that regard. This should always be done when you have metabolic acidosis. Because when there is no metabolic acidosis, why would somebody want to acidify the urine? So the parameter to look at is urine and blood CO2. The role is that if the level is low, this is distal RTA. If it's high, it's proximal RTA in that regards. Now, based upon these things, we can classify into different forms of RTA. So bicarbonate, typically, if it's very severely affected, this is more likely to be distal. Mildest is type 4 and proximal is slightly in between. Potassium is pretty much low, but if it's very severely low, I'll think this more like a distal RTA. While on treatment, if it becomes low, it's proximal RTA. If it's high, of course, we are talking about type 4 RTA or a very, very rare form of hyperkalemic distal RTA. Urinary pH should be below 5.3. If it's above 5.3 in acidosis, you're dealing with either distal or rarely type 4 RTA. Urinary calcium is usually high in distal, but a high urinary calcium does not exclude proximal RTA. We have discussed that proximal RTA also has hypercalciuria. Why do you have hypercalciuria in RTA? So, the major cause of hypercalciuria, hypermagnesiuria and everything is because of your sodium. So because of that gradient, that you have a problem. So potassium is being lost, all the positive ions will be lost. This is part of the RTA picture. So Fe bicarb, as I said, will be high in the setting of proximal RTA as compared to the other forms, and ammonium production will be low, especially in the distal RTA. So metabolic acidosis, look at anion gap. If it's high, think of diabetic ketoacidosis, organic acidemia, lactic acidosis. If it's normal, look at urinary anion gap. If urinary anion gap is negative, which means that ammonium production is normal, this is GI loss. If urinary anion gap is positive, which means it's a renal tubular problem, it is RTA. Look at potassium. High potassium means type 4 RTA. And then to distinguish between proximal and distal, urine pH is a good measure to look at, and Fe bicarb also can be assessed. Now, when you're measuring urine pH, what precaution will you take in taking that urinary sample? So you can put a drop of oil and then you collect the urine. So oil, because of surface tension, will be, or the density will be on the higher side, and then you can easily assess from that perspective. So then you can classify them into a proximal versus a distal RTA in that regards. So 3-year-old boy with failure to thrive and hypokalemia, there is metabolic acidosis, bicarbonate is low. What you're seeing here is anion gap is normal and urinary anion gap is positive. So what are you thinking, Dhwani, here? So we have to do a creatinine. Also, although hypokalemia makes it a bit very less likely to have a primary glomerular disorder. So in that scenario, urinary pH was 7.5. So this goes more in favor of a distal RTA, and Fe bicarbonate was high. So what do you think here? So this is what we discussed as the first case, that you have to think of urine RM. So before you look into urine pH, look at urine sodium, look at urine RM to decide whether you really have a urine pH which is reliable. This case we already discussed, 12-year-old girl with multiple fractures, failure to thrive. Again, a case of distal RTA with diagnostic confusion in that you had amino acid urea. So why is there amino acid urea in distal RTA? So secondary hyperparathyroidism can cause glucose-urea, amino acid urea, Fanconi syndrome-like picture. But the key message is look at the case. The first case was a young child who had presented very early. That's more like a proximal RTA. This is a later severe presentation, more like a distal RTA. Fractures I have generally seen is in the setting is mainly with distal RTA or very, very young children, then it's proximal RTA. So this becomes important. 4-year-old boy with rickets, calcium is 8.2, potassium is 3.8, phosphorus is normal, ALP is high. So this is a case of rickets. Base excess showed mild metabolic acidosis. He has not been given a lot of vitamin D till now. But because somebody thought that this could be RTA, they did a pH which showed metabolic acidosis mild and a normal anion gap. And then they labeled the child as distal RTA based upon a urinary pH which was 5.6. So do you think this is distal RTA? Why is ALP normal in RTA?
It's the turnover is less, the bone turnover.
Yes, so ALP is a marker of bone formation. So when you talk about other causes of rickets, you have got more formation, more resorption. In RTA, everything becomes less. So that is one sign. What else?
So if we see low calcium, so it could be due to vitamin D deficiency, and long-standing vitamin D deficiency causes secondary hyperparathyroidism, and that can cause mild acidosis as well as the Fanconi.
Yeah. So the level of acidosis that we are seeing here is also not very significant. Now, many times I have seen people say, okay, let's do an ammonium chloride loading test to see whether this could be RTA as a covert, incomplete distal RTA. This is a concept which comes largely from adult studies. Now, that's predominantly for patients who have renal calcification. To my experience, I have not seen a patient who comes to me with distal RTA particularly with fractures and bone disease without a severe metabolic acidosis. So what I'm trying to say that people say, okay, you may have a compensated RTA and still rickets. That's not the case in children. So if you have a pH and bicarbonate level of which is mildly problematic, I don't say that this is contributing to RTA. This is the effect of RTA. This is the effect of rickets rather than the cause of rickets. So to speak, this is secondary hyperparathyroidism, and vitamin D should be done in this case, which was very, very significantly deficient. Now, once we know the type, we can then go about evaluation. So we've discussed in detail about various drugs. So drugs like anti-cancer drugs, antifungal drugs, then many of these antipsychotics along with anti-epileptic drugs can cause this scenario. Always look for eyes, and we have a couple of patients who have problems which in terms of cystinosis and other disorders which can cause the same scenario. Hearing abnormality is very, very common, and this is what Dhwani had talked about, distal RTA. So always ask for that. The genetic form may often have hearing abnormality. And liver disease, there was one girl with hypothyroidism and distal RTA. I think she had the same sort of a picture. And hepatomegaly, very common, would be in the setting of glycogen storage disease, fructose intolerance, and Wilson's disease, which you have to be worried about. Further workup for distal RTA should include an ultrasound for nephrocalcinosis and an autoimmune panel. Sjogren's syndrome we have seen quite often. SLE has already been reported. Proximal RTA, you have to rule out genetic causes. So generally, we would now recommend a panel to look for genetic causes of proximal RTA. You can find problems in the GLUT transporter. You can find problems in the cystinosis as well as other tyrosinemia genes as well. Type 4 RTA, you have to work up like a hyponatremia, hyperkalemia. Management, of course, for distal RTA, mainly you have to give bicarbonate. The initial requirement of bicarbonate may be high because you have deficit for a long time. So you may require 6 to 10 millimoles per kg per day to begin with. Subsequent requirement becomes less. Once you give bicarbonate, your acidosis becomes better, your potassium excretion becomes better. your potassium may become normal. So as we were discussing, you will have hypokalemia at diagnosis, which improves with treatment in that setting. So options are sodium potassium citrate, or now we often use just sodium bicarbonate in the form of tablets as well as liquid suspension, which is available. So sodium bicarbonate is something which is quite good from that regards. You aim to maintain bicarbonate in the normal range because low bicarbonate will cause bone defects to continue. You want to initiate at a high dose and maintain around 1 to 2 millimole per kg per day. Preparation citrate, or as I said, bicarbonate is preferred. Citrate may be helpful because that may help in preventing calcification as well in that regards. Ultimately, citrate is converted into bicarbonate. If there is persistent hypercalciuria, we need to avoid salt intake. So often these patients will have a lot of salt, so that you have to avoid, and thiazide diuretics can be added. And you can then prefer a potassium salt also in that regards. Monitor urinary calcium, do an L1 ultrasound and renal functions in that regards. You expect improvement in height, in bone. Hypercalciuria will improve if you give sodium salt. Increase if you give sodium salt. So you have to be careful, and you can think of potassium, as I said, in that scenario. So this becomes relevant from that regards. For treatment of proximal RTA, you have to be giving more amount of bicarbonate, but more bicarbonate you give, you will be losing that bicarbonate. It is something like treating hypophosphatemic rickets. If you give more phosphorus, you will lose more phosphorus. So it's very difficult to maintain a good amount of bicarbonate. So as I discussed earlier, proximal RTA is a milder form, more difficult to treat. Distal RTA is a severe form, more easy to treat. So here you would need a very high dose of bicarbonate. And once you give bicarbonate, as we discussed, if you have a sodium load, you will have an exchange there and you will develop hypokalemia. So here hypokalemia will worsen during treatment. So you have to be worried about. You expect improvement in growth. You need to give phosphorus as well because they also lose a lot of phosphorus. So you have to give them phosphorus in the form of an inorganic phosphate, and polyuria will improve. Potassium may worsen. So you start at around 10 to 15 millimoles per kg per day. Sometimes adding a thiazide and an amiloride may help in this regards. It reduces your bicarbonate requirement. Potassium, you have to start. While in distal RTA, often you may give potassium to begin with, and then you can be able to take it off. And phosphorus supplement, as I said, at a high dose is required from that regards. There is a risk of hypokalemia, and you may need to give vitamin D, and the condition improves over time. You have to monitor after a week, maintain bicarbonate level more than 22, and then monitor 3 monthly. Type 4 RTA, the cause has to be treated. So if you have hypoaldosteronism, give them aldosterone. If it's pseudohypoaldosteronism, you give them soda bicarbonate, fludrocortisone, more sodium, soda bicarbonate, and then voltage defect, you have to give more sodium in that regards. Often it may be a self-limiting acidosis, hyperkalemia.